I wanted to do something slightly different from the normal surgery for cavernous malformations that you usually get burdened with me, and wanted to talk a little bit about a couple of things that I think are very important and lead to a lot of thought and pondering for families about what is right and wrong. I'll go through a little bit about my background quickly, and then we will start talking about screening and look at the three aspects of screening that we've got here. So the clinical side of things, the imaging, and a little bit about the genetics. As David said, we'll have a little pause for any questions, and then talk about activities with Cavernomas, and then some more questions at the end. So there's a reason for the American thing. So after I did my general neurosurgical training in the Northwest, I did fellowships in North America, 2 of them. The first one was at Boston Children's Hospital, and that was with the 2 people here. Michael Scott was the senior mentor there at the department, who has a particular interest and did for many years in vascular problems for children in their central nervous systems, and has been a pioneer for all things vascular. And at the time I was there, Ed Smith was the chief fellow, and now is the director of the cerebrovascular service there. And again, he's a very good friend to us in Manchester and the UK, and Cavenoma Alliance. He's done talks for us in the past on several occasions, and they're both absolutely wonderful people. And it's what sparked my interest in cavernous malformations and vascular problems for children. I then did another year's fellowship in Sick Kids in Toronto, another excellent world-class paediatric neurosurgical unit, and seeing a lot of patients with vascular problems. So in 2005, moved back to the then Royal Manchester Children's Hospital based at Pendlebury. And then it's about 11, 12 years ago, we moved to our new site, the thing that you can see behind me, the new Royal Manchester Children's Hospital on the central Manchester site. Here is the real key for me. So from that time, starting in 2005, we've tried to build up our neurovascular service, and the key to that is the team. You've heard already this morning from Grace Valsalva there that you can see. This is us doing one of our MDT clinics just before lockdown. I think you'll find, hence the no masks thing. But also we have Deepak Ram from Paediatric Neurology. There's Ed on one of his occasions he visited us in the UK. This is Rebecca Keeping Becks, our neurovascular specialist nurse, Dimitrios Bartholitis, paediatric neurosurgical colleague, and Stavros Sivaros, paediatric neuroradiology. We've got other neuroradiology colleagues that take part in the neurovascular service: Chris Hiljic, Hannah Stockley, and Amit Hawadka. And lastly, but by no means least, because he's helped with some of the slides today, is Stuart Rust, our paediatric consultant neuropsychologist, who is a big part of the team. So let's get going with the clinical screening. I'll cover, talk a little bit about what does it entail, why would you undergo clinical screening, and then a little bit about advantages and disadvantages. This is obviously a self-selecting audience that knows that they have cavernous malformations, but as you are very aware, that's not always the case. They can present in a variety of different ways, from being symptomatic with the headaches, bleeding, neurological symptoms, or fits, seizures, going on to epilepsy. But you can be aware that you may or may not have cavernous malformations based on a family history. There's a risk of cavernous malformations if you've had radiation to the brain and central nervous system. And increasingly so, cavernous malformations will get picked up as an incidental finding. And so a lot of this decision making on how then that should be managed is part of the talk today. So what does clinical screening entail? Well, I think that's very different depending on where you might be, what your circumstances are, what problems you have with the cavernous malformations. But this is an example of the kind of people, some of which you've seen already, that form part of that team. So you may, clearly you are always under the care of your general practitioner, but in terms of specialist care, you may well be under neurologists, neurosurgeons, geneticists. Incredibly valuable part of the team that we mentioned is our nursing colleagues, our specialist nurses, and particularly epilepsy specialist nurses, and also the psychology members of the team, looking at both the cognitive and emotional well-being. So any cognitive problems that having a cavernous malformation may have caused from symptoms, and also how the whole disease process is affecting the individual and their family. And certainly for us in Manchester, we see this as a lifelong care thing. So there are differences between the care that you may need and would receive as a child with a cavernous malformation, as an adult. For our paediatric service, and clearly as I am a paediatric neurosurgeon, a lot of this will be biased towards paediatric things. School liaison is an incredibly important thing, and Bex does a fabulous job liaising with all the schools of our children. And very importantly, within Manchester, we feel that transition from paediatric to adult services is really important. The other person you didn't see on any of the pictures is Dan Holsgrove, who is an integral part of our team, who is an adult neurovascular neurosurgeon. So he joins our clinics. We do operating together, and see that as a really important part of the lifelong care of our patients, because often that transition time from children's services, you've been at a children's hospital for many, many years and used to that, moving over to a big scary adult unit, we appreciate can be a very difficult thing. Okay, so what are then some of the advantages and disadvantages of just that purely clinical screening if you have a cavernous malformation? So clearly you've got access to a healthcare team that are aware of your condition and are available for advice as required. But clearly if you start with new symptoms, you would have rapid access to that team. We mentioned the very vital work in supporting education and also work. And being available to decide and discuss the need for any further investigations, or talking about the balance of benefit and risks with the various types of treatment. What are the disadvantages? So coming to clinics does involve time away from school or work on a regular basis. And we'll talk later in this webinar that many people with cavernous malformations, as you know, will never have a problem with them the whole of their life. So are you potentially unnecessarily medicalizing the condition, potentially investigating the condition when it's not necessary? Those are potentially some of the disadvantages. Okay, so moving on to imaging and screening with imaging. So the main forms of imaging that I'm sure everybody is familiar with are the CT scan and the MR scan. Angiograms, as in catheter angiograms, would sometimes be performed for vascular problems within the brain, but again, I'm sure most of you would know that cavernous malformations are what's called angiographically occult vascular malformations, as in they do not show up on an angiogram, but if there was any sort of doubt, then potentially an angiogram might be performed. But the mainstay of investigation is CT scan and MR scan. You can see the scans. I'm sure many of you are intimately familiar with them. The CT scan, they're both tunnels, donut-shaped things. The CT scan is more open, the MR scan more claustrophobic. But this is our one at the Children's Hospital. For the children have headphones so they can listen to music, and now actually have a video screen in the scanner as well, so that they can watch things as they're having the scan, which for sure makes things a lot easier. I'm sure you're all very familiar with filling out safety questionnaires for MR scans. And you can see here's why you have to do that. So this is a scan picture that Stav had given me. This is a normal hospital bed that is clearly metal. And you can see what happens when it was wheeled into the MR scanner. And literally, this will have flown across the room into this position. So you see why it's so important that you've not got any metal bits on you. So these are a couple of the images that you'd get from the scan. So on the right here is a CT scan, and on the left an MR scan. So the CT scan shows the density of tissues well. So the bone shows up as white, being very dense, and that can be helpful in diagnosing cavernous malformations in that they are sometimes calcified. You can see a little fleck of calcification here within the cavernous malformation. And CT is also very good for showing fresh blood, because that also shows up as white, and can be very helpful immediately after symptoms if there's concerns that there's been a bleed. The MR scan shows the tissues in more detail, and this is a typical kind of appearance of a cavernous malformation. The same patient with a sort of mixed picture in the center, and this dark rim around the outside where there's been bits of oozing of blood and staining of hemosiderin blood products. The MR scan can also perform specialized sequences that are particularly helpful for cavernous malformations. So these are the standard kind of sequences on the left here, the so-called T1 and T2. And it's really looking at the anatomical structures of the brain. And you can see even between those sequences, these small cavernous malformations look slightly different and show up slightly different based on those different sequences. But this is a type of sequence that should always be done if looking for cavernous malformations, and it gets called their names. This is SWI, susceptibility weighted imaging, but it's also called things like gradient echo, T2 star, various different things. But the blood products, again, within a cavernous malformation show up with this bloom artifact. So they're overemphasized and far bigger than they actually are in real life. So it clearly shows the cavernous malformations and can show very tiny cavernous malformations that would not otherwise show up on the anatomical imaging. So in terms of having a scan for sort of screening purposes, what are the risks of doing that? Well, for the CT scan, it's X-rays, it's radiation. And that dose of radiation to do a CT scan is relatively high. It's far, far higher than having just a chest X-ray, for example. And a study from a few years ago looked at this and found that one of the risks with giving radiation is that you can actually cause tumors. The most typical would be a benign form of tumor around the lining of the brain, a thing called a meningioma. But the risk of that per CT scan of the brain is roughly 0.08%. So you can see you'd need to have 100 scans of your brain to give you about a 1% chance of developing a tumor of some sort. And that was with older scanners. The newer scanners are more efficient. They give you less of a dose, so that risk is probably lower. One concern of giving CT scans to children is the potential for causing damage to the growing brain. So we would be reluctant to do CT scans. Most of the time, for a child presenting, MR scan would be the scan of choice. In terms of risks for MR scan, there really are not any proven risks for MR scans at all. They've been done for many, many years, and there are no real concerns for undergoing an MR scan and being in that strong magnetic field. The only risks would be if you had things like pacemakers and didn't mention it, then there's a risk that that device can fail or run into difficulties as a consequence of the MR scan. Some of the other problems, though, of having scans for screening purposes are down the bottom here, that you can you have this chance of finding an unrelated abnormality, and that's a very common thing. And cavernous malformations are a very typical example of that. That you're having a scan for some other reason, and a cavernous malformation is identified on that scan, and there you are in a position where potentially that has to be investigated further or potentially treated or not. For our children, and certainly for some adults, an MR scan is a very claustrophobic, noisy thing, and there is a requirement for them to be either sedated or, if a little bit bigger, to have a general anaesthetic, and that works for adults as well. Some adults are claustrophobic, cannot tolerate an MR scan, and need a general anaesthetic, and therefore have that risk of having a general anaesthetic. And again, a figure I have in my head that I would usually say is there's a 1 in 300,000 chance of dying with having a general anaesthetic. So that's a tiny risk, but it's not a zero risk. And lastly, and very importantly, is clearly the psychological impact of the result of that scan and what it means to that individual. So just thinking about that in a little bit more detail. So if we think about what might be the outcome of having an MR scan, that's either if you are, there is a family history of cavernous malformations, or it's suspected you might have cavernous malformation, or you've had a scan, some investigation that would be suspicious that you have cavernous malformations. You thinking about it, you do a scan and you might find that there are cavernous malformation. There is one, there might be multiple, they may be different sizes, there may be evidence that they have bled in the past, and they may be, importantly, in different locations within the brain. They might be in less important areas, but they might be in more important areas, such as the brain stem. So you could argue that you might have a very mild scan, you might have a moderate scan of those changes, or you might have severe worrying features off that scan. Then, if you are going to go on and have a screening process, then that scan potentially would be repeated. And the outcomes of that are that the appearance from that first time may be stable, and again, as I'm sure you're familiar, sometimes the appearance can actually improve. That cavernous malformations with time can get smaller, but it might show that the changes are worse. There is hemorrhage that has occurred without any symptoms. There is growth of a cavernous malformation. So clearly, in terms of the psychological impact of undergoing that scan or undergoing repeated scans, if we're down this end of having mild features or stable appearances on scans, that's obviously reassuring. But up at the top here, or things getting worse, clearly there may be a worrying result of that, even if you're not having any symptoms, and this has just been picked up from that scan. So an example of where this can be helpful. So this is that scan that we saw before. This was one of my patients from a few years ago. That was their original scan, a single cavernous malformation. But they went on to have screening, and over subsequent time periods, you could see that cavernous malformation slowly got bigger. So this is scans going from year to year, and eventually the cavernous malformation reached this size. So this is in what we'd call a high risk area for sure. This is the brain stem, so it's just abutting into the brain stem. these are the deep structures. This is very central within the brain. But because this was at this point starting to cause symptoms as well, we knew this had grown to this stage. We were able to have that information to say, look, we really need to do something. If we don't do something, almost certainly things are going to get worse. So the patient was able to have an operation, and even though this was a high-risk area, we're able to go through safe corridors, which is this little channel here. You can see coming in from the side. This is a front-on view, so you can see the little channel that we went down to get to where the cavernous malformation was. And at the bottom here, there are changes around where it was, but the lesion was completely gone. And again, this is a side-on view showing that little, it's like a little letterbox that we would go down to get to the area to be able to remove the lesion. So this is an important thing that we'll come on to in a second here, in that it's so important to think about the psychological impact of what that screening may have. And again, thanks to Stuart Rust for his help with some of these slides. So we know that children with a chronic illness are twice as likely to present with psychological difficulties as to other children. And mothers of those children will, in general, have poorer mental health. And also siblings of those children are likely to have higher mental health problems compared to other children. So this is a potential worry, clearly. But this is evidence and study looking at chronic condition, another condition, not actually cavernous malformations, but it's a very similar situation. And this paper looked at some of the factors that are of benefit in terms of living with a long-term condition. So this first one, it's vital that there is access to a treatment. If there is access to a treatment, this does improve optimism. So, and the converse is true. If there is no treatment for a condition, then it increases anxiety to know that you have that condition. So for cavernous malformations, knowing that there are treatments available is an important thing, and that has to be the case to warrant doing screening of any sort. It's important to take one day at a time and delay worrying. You could argue that is an argument for saying, okay, then why screen? Let's just wait for problems to happen. But this next statement is also really important. Understanding the condition and knowledge of that condition facilitates this sense of control, and trying to gain control over the condition is a vital thing in terms of ultimately living with that condition long term. You all are doing this already in terms of talking to other families going through the same thing, and that was shown to be a very positive and beneficial thing. And lastly, trying to normalize life and routines, and we'll come on to that when we talk about activities, is really important. So a couple of years ago, there was a very nice paper from the sister organization in North America, the Angioma Alliance, and Rustam, one of the medical director for our Cavernoma UK, was part of that paper. And if you've not seen it, it's a very helpful summary of guidelines for managing cavernous malformations. And these are their recommendations regarding imaging. So MRI scan is the recommended thing to diagnose cavernous malformations. That should include that gradient echo thing that we talked about. Catheter angiogram is not required for cavernous malformations. And the last bit was a little bit more clear cut in terms of advice, in terms of follow-up imaging. It advised it should be considered to guide treatment after new symptoms. More imaging should be performed, but it wasn't very specific about how you should follow up with repeat scans. Within Manchester, within our group, what we like to do, for some of the reasons I've really just summarised, is to know what the situation is with the cavernous malformations, and to know Is it something that's changing and that would be a worry and something that we could potentially act on? So we would usually, after a diagnosis of cavernous malformations, undertake annual scans for a couple of years. And if we've seen stability on those scans, if they've not changed at all, at some point either stretch out the period between scans or stop doing it completely. Okay, so moving on to the genetics, and this is, I'm not a geneticist, you could have a whole talk on genetics, so this is just really touching the surface of the genetic side of cavernous malformations. Again, I'm sure you're all familiar, there are three main forms of gene mutations that have been identified, CCM1, 2, and 3, and these are their relative frequencies, but that depends on whereabouts around the world that you are. There will be a smaller proportion where we know there's a family history, something is being passed on, but the gene is not identified. But that's actually a very small proportion now. When considering whether or not genetic screening is a helpful thing, genetic screening does not mean that you just go, you have a test and you get told whether you've got a mutation or not. It's a far bigger package of care from the genetic team. So you would meet a genetics consultant, usually with a genetics counsellor, who would discuss all aspects of how, what they have to offer and advice and care that they can give. And part of that is testing and looking for these gene mutations, but it's not the whole thing. In terms of what a positive test would mean to that individual, then there are various aspects and terms that you, I'm sure, may have heard or would be familiar with. So having a positive test that you've shown to have a mutation in one of the genes that we've talked about before, that describes your genotype. So if you've got a mutation, your genotype shows that you have a mutation. But how that shows itself in an individual then is described in these other couple of terms, the penetrance and the expressivity. And this little diagram describes what those two terms mean. So penetrance describes if you have the genotype, so you've definitely got the gene mutation. It describes what your phenotype is, so what actually you show of the disease itself. Are you going to show disease or are you not? And some patients and some conditions will definitely have the mutation, but will not show any evidence of having the disease at all. Some will clearly have it, others will not. For cavernous malformations, it's felt that the penetrance is actually quite high. So if you have the mutation, if you have the genotype, then you almost certainly will have the phenotype of some cavernous malformations. But that's where it comes into the second aspect of this, the expressivity. So certain conditions will express themselves differently. So although you have the gene mutation, you may express the condition in a broad range of different ways. So this middle group here, this is really what cavernous malformation mutations are like, that the penetrance is high, but the expressivity is wide. So some people will be more greatly affected than others. The penetrance is not 100% in cavernous malformation, so it's a little bit like this, but we'll just come on now to look at those figures in a bit more detail. So there was a nice paper from 2004 looking at the CRIP1 mutation and looking at 200 patients that definitely had the CRIP1 mutation. So their genotype was positive. And in those patients, they found that the vast majority, there were only 5 patients that they looked at that had a scan, and not all the people who didn't have symptoms had a scan. So that's why the figure is a bit variable here. But there were 5 patients between the ages of 27 and 48 years old definitely had the gene mutation, but had no hint of any cavernous malformations whatsoever. So a small proportion, and therefore a fairly high penetrance. The age of clinical onset on these patients was just about 30 years, but you can see a broad range of when patients presented for the first time. And within that group, only 62% were ever symptomatic. And you could argue, looking at that snapshot, this is sort of, you could argue, the minimum figure for being symptomatic if within the genotype, because clearly some of these patients ultimately down the line, the 72-year-old was only 72 when they got their symptoms for the first time. There will be some of these others that were asymptomatic that in their lifetime may well be symptomatic. But there is a large proportion of patients with the CRIP1 genotype that will go through the whole of their life and never have any symptoms whatsoever. A little plug here for things that I'm sure you're very familiar with already, but there's an excellent information booklet on genetics, as well as many other excellent information booklets on the Cavenoma Alliance website. Okay, so just finishing off, thinking about the advantages and disadvantages. So finding out about the conditions we talked about before has the potential for an individual, a family being able to take control of the condition, which psychologically is an important thing. And also, as you've seen, it allows a potential for early interventions along the clinical course. But we didn't touch on it because I said it's a bigger topic altogether. There is the potential in terms of the genetics advice for people thinking about having children, and also the possibility of pre-implantation diagnosis and other genetic techniques that are changing all the time that may allow the ability to understand who and which future children may be at risk of the condition. Very importantly as well, knowing that you have the condition allows the possibility of early adoption of future therapies. So there's already very exciting data on things like statins and beta blockers as potential medical therapies for patients with cavernous malformations. To know that you have the condition, to be potentially able to take part in clinical trials for these things is a very positive thing. And an example, this is something over the next 10, 20 years is going to change dramatically within medicine. In Manchester, within the next few months, we're about to start 2 separate gene therapy studies looking at other conditions. I hasten to add, not cavernous malformations, but this is delivering. So this is patients with conditions that have a faulty gene that affects their central nervous system, where we are delivering the corrected gene to them directly into the central nervous system. And this is going to be the tip of the iceberg for future therapies. There are so many things that are coming along in the future. Thinking about the disadvantages, there is no question, and I have seen it in many of my patients and families, that understanding that you actually have the condition can have a negative psychological impact. And ironically, as well as taking control, it can mean that you feel you have a loss of control over what's going on, and that the age-old ticking time bomb is there. And as again, I'm sure you are familiar that having a diagnosis of a proven diagnosis of cavernous malformation can have implications for health, travel, life insurance. So it does remain the question: is ignorance bliss, or is it really better to know what you're dealing with and try and tackle it head on? So these were the recommendations for the genetic testing from that paper that we looked at earlier. it is absolutely right and very sensible that a family history is taken with a new diagnosis. There is a consideration, rather than it should be done, for genetic testing for familial forms. They've put here that if you have multiple cavernous malformations, the reason being, if you do have multiple cavernous malformations, there's probably a 75% chance that you do have a familial form, but without an associated DVA. A DVA is a developmental venous anomaly. They put that in because of a paper a few years ago. So this is a CT scan on a patient. That's their cavernous malformation, and this is a developmental venous anomaly. It's described as a Medusa's head, this sort of starburst of abnormal vein here. And there is a very close association between the two, but this paper showed that it was only really the sporadic cases where you got a DVA along with a cavernous malformation. And if you saw that in familial cases, it was possibly less likely. I think there are questions on that paper. It's not an absolute thing. And I think if you have multiple lesions, then I think genetic testing very seriously should be considered. And then it talks about what we discussed earlier, that if you are known to have the gene mutation, then testing of family around you raises ethical and psychological questions, and there is no right and wrong answer. From the point of view, again, of what we try and do as a team in Manchester, what we try and do is give our patients and their families as much information as we possibly can, and together try and make the decision about what's right for them and all the members of their family. Okay, so that's the end of the first bit. Shall we pause for some questions?
Yeah, thank you for that. That was really interesting, and we've got a few questions that have come through on the chat. The first one's from Pat, who has asked, is screening different to diagnosing?
So technically, screening is the process of undertaking a test where you're not necessarily, you don't know what the answer is going to be. So in terms of cavernous malformations, I see screening in the terms that I was suggesting, that the clinical screening, that you would come back to clinic even though you might be perfectly well, and the purpose of that is to just try and identify things that may not be immediately obvious, or support things that may not be immediately obvious. The MR scans, you're doing a scan not because of symptoms, you're just doing it anyway to see if there were changes that you were unaware of. So that's the slight difference between that sort of screening and making a diagnosis.
Thank you. The next question is there any evidence that radiation from frequent flying increases the risk of developing a Cavenoma?
So you do experience radiation when, for lots of different ways, you get radiation. Not being at altitude, everybody gets radiation as background radiation the whole of the time. It's higher when you go in a plane, but it is not at the levels that are required. So this is the patients that get cavernous malformations have received very high dose radiation as treatment for other tumours, usually in the central nervous system. So there is absolutely no evidence that flying gives you the level of radiation that would give you cavernous malformation.
Okay, that's great. We get asked that question a lot, so that's good to have that clarified. Next question is, at what age would a child be expected not to be given an anaesthetic for an MRI scan?
Yes, I was going to mention that, but I didn't want to go into bore you too many details. It is a very good question. So we would so in very, very young babies, we would sometimes, if we need to do a scan of some sort, just avoid feeding them, then give them a big feed and wrap them up, and they'd usually fall asleep. That doesn't work very long, and from that point on, we would in Manchester would use sedation. That usually only works up to about 20 kilograms of weight, and then the sedation, you can't give a higher dose, so it loses its effect. That roughly gets you about 4, 5 in some children, and the usual time when we'd expect a child to routinely be able to undertake an MR scan is a little bit later, so it can be about 5, 6, 7, 8 sometimes, depending on how cooperative that individual is. So there's a little window where often then the general anaesthetic is needed for those patients that can't tolerate it. And obviously, as I say, some adults just can't tolerate it, and that is very reasonable.
Thank you. Next one is about the genes. Is it dominant, hereditary, or recessive?
Yep, so they are all autosomal dominant, which means that generally, if you have the condition, then one of your genes is faulty. And apologies again, I'm not a geneticist, so this is very amateur stuff, but one of your genes is faulty. So if you have a child, you might pass on that one gene, you might pass on the gene without the mutation. So there is a 50-50 chance in any child that you have of passing on the condition.
Brilliant. Okay, next one is, at what age would you allow a sibling to have genetic testing, as the gene runs in 3 generations of family?
Yeah, so this is where there are absolutely no right and wrong answers. The question is, what are you going to do with that information? And it's how a family perceives wanting to know that information, how they are going to manage that information. And as we talked about, it's a double-edged sword. It can empower you to say, right, we know what the situation is. And again, be thinking about future therapies, etc., going forward. Or you could argue, we're not going to be treating, we're not going to be scanning at a very young age. Why on earth bother doing the gene test? There is no right and wrong. It's a matter of a discussion with the family together to decide what's right for them. It is usually a blood test to do the gene test, so it's to decide whether or not that's the right thing for them.
Okay. Thank you. I think there's one more on the chat link. How is a faulty gene connected to a Cavenoma? That's from Snell.
Yep, so they are different genes, the CCN1, 2, and 3. They are involved in blood vessel formation, so presumably having one gene that's faulty means that the blood vessels don't form right, and it prompts the cavernous malformations to form. With most conditions that are genetic, there are environmental factors as well that may have an effect. At the moment, there's no obvious environmental factor that we're aware of that changes the formation of cavernous malformations. But an extreme example is the radiation. So that's an external factor that has caused something to change within the cells that are making that cavernous malformation in that individual. But that's the situation with how they form.
Thank you. Thank you, Mr. Kamaly. Has anybody got any questions they'd like to ask directly before we move on? Can't see, I'm checking. No? Okay. I think we're good to go to the next part.
Great. Okay, so in terms of activities, I wanted to try and cover a few things here. The most frequent thing that I would get asked is the physical kind of activities, but there's also these other things that we'll hopefully cover in the next few minutes. Okay. So in terms of the physical activities, there are a broad range of things that get asked about, whether they are permissible or not, or sensible or not. So if you're doing sport, that might be non-contact sport. It might be very strenuous activity versus not so strenuous activity. Clearly, contact sport, is that a sensible thing to do? There are theoretical risks in going at altitude for prolonged periods of time. That can affect various things, including vascular growth factors, and it is suggested that that might have a negative effect on cavernous malformations. The last couple relate to more the epilepsy risk. So we know that epilepsy is a risk for somebody with a cavernous malformation, and there was one study really that looked at the risk if you've never had a seizure before, if you know you have a diagnosis of cavernous malformation, what's the risk in the next 5 years of you having a seizure? And that study showed that if you'd had a bleed before, your risk was 6%. If you'd not had a bleed before, your risk was 4%. So you could average that out at around about 5% or 1% risk per year. So if there is that risk, it makes a lot of sense that you avoid epilepsy risk activities such as scuba diving, swimming alone, that kind of thing. The one thing that often gets asked, going on high-speed attractions, roller coasters, bungee jumping, those things give forces to your body, but generally those forces are provided in a fairly linear way rather than stopping sudden decelerations necessarily to your head. And the other thing that is interesting, you know, is there any risk in just straining for whatever reason? So a Valsalva Maneuver, you may or may not be aware, is where if you hold your nose and mouth and blow out and strain like that, that's a Valsalva Maneuver. Should you do that if you have a cavernous malformation? There have been a couple of studies that have looked at that and generally have found it not to be an issue, but there have been ones that have found symptoms come on in patients with cavernous malformations and the developmental venous anomaly that we talked about before, just by only when the patient undertook a Valsalva Maneuver. My general approach to families and patients is to talk through the risks. So we know there are patients that have been reported to have had a bleed from a cavernous malformation, and immediately prior to that there has been some head trauma or contact. It's from our own experience of all our patients, when we looked at this, there were only 2 where there had been a possible bang to the head. One child fell off a bike and the other had collapsed in the bath. But it's uncertain, was the bleed first, the chicken and egg thing? Did the bleed happen and then they fell off their bike or collapsed in the bath? Or did they fall, bang their head and cause the bleed? And it really is not known, that answer. There was a nice study from last year, actually, from the Mayo Clinic, looking at their 195 patients. And they looked at 2 features around this. So of their patients, they looked at the 76 that presented with a bleed, and they asked them, did they report anything unusual prior to that bleed? And only 16. So the vast majority of times when there is a bleed from a cavernous malformation, you're doing nothing in particular. It wasn't associated with anything that you could recollect. 5 were associated with strenuous activity, 3 with head or spine trauma, 3 infection, inflammation. There was 1 described as cessation of breastfeeding. I'm not sure if that was the mother had ceased breastfeeding or a child who had ceased breastfeeding recently. There was 1 associated with emotional stress, 1 excess alcohol, 1 non-compliance with taking blood pressure medication, 1 patient who'd been high altitude climbing. But you could argue, is these true associations or were these genuinely just coincidence? Then they looked at their group and gave a survey of which 103 patients responded. They were followed up over a total of 540 odd patient years, so around 5 years per patient on average. And during that time, 23 of them suffered a hemorrhage. And they'd done a questionnaire of their activity levels prior to that hemorrhage in terms of regularly doing these activities, so more than 3 times a month. And they looked at walking more than 20 minutes, running or jogging, lifting more than 20 pounds, 9 kilograms, lifting less than 20 pounds, non-contact sports and contact sports. And they found no difference whatsoever in whether you undertook these activities or didn't, and were known to have a cavernous malformation and suffered a hemorrhage. The contact sport numbers were very small, so it's hard to draw absolute conclusions, but generally reassuring that quite possibly these things are not having a negative effect. So again, the kind of things we do in Manchester is that we talk through these kind of risks with the patients and families, I would usually be reasonably relaxed, but say, it makes sense that if you've got this blood vessel thing in your head, you probably should avoid activities where blows to the head are an integral part of that activity. So boxing, martial arts, other things like that. To me, the balance of risk and benefit probably is in favor of not undertaking those activities. But otherwise, if there's something that you enjoy, then important, I think, to not feel restricted. And we'll talk about that in a bit more detail in a second. So moving on to pregnancy. So there have been a couple of big studies looking at this. And those studies have shown there is no difference in symptoms occurring or bleeding occurring during pregnancy. And importantly, there appears to be no extra risk having a normal delivery as opposed to a cesarean section. So I suppose the Valsalva maneuvering that you're doing and the straining that you're doing during a normal delivery puts the lifting 9 kilograms to shame, I think, but shows that those activities can be undertaken without predictably causing bleed from a known cavernous malformation. One thing that is very important is if really important to consider anti-seizure medication that anybody might be on. Some of them, as I'm sure you're familiar, are teratogenic. They can affect the fetus, and it's very important that a pregnancy, as much as possible, should be planned in those terms, and the usual important things like taking folate, etc., given as part of that planning. One thing, again, that I think is very important to consider is not just the pregnancy and the delivery, but afterwards and that very difficult period, looking after a very small child. The parents will be tired, they will be feeling under the weather and unwell. That is a very recognized risk of increasing the chance of having a seizure and lowering seizure thresholds. Lastly, a few things. So medications and smoking. Again, this has been looked at, but there's no randomized controlled trials that have taken a group, given them these medications compared to not giving them. But the evidence that exists would suggest that taking antithrombotics, antiplatelet tablets like aspirin and things like that do not have an excess risk if you have a cavernous malformation. And thrombolysis, clot busting things that would be given for heart attacks or strokes do not have a negative effect on patients who have cavernous malformations as well. So important, if those things are required, then it's something that very much should be considered, and no evidence that they would lead to excess harm with the cavernous malformation. Another very commonly used thing, non-steroidal anti-inflammatory drugs like Ibuprofen, diclofenac. Again, of the small studies that have been done, there's no evidence they have a similar effect to the aspirin, but it's shorter lived. There's no evidence that they cause problems with cavernous malformations. And I've put here, lastly, there is no evidence, unfortunately, that smoking directly increases the risk of symptoms. It would be nice for health reasons to be able to say with great clarity, but I think most people would agree that you don't really need a randomized controlled trial to suggest that doing something like smoking that we know affects blood vessels is almost certainly not the best thing in the world to be doing if you have a problem with blood vessels of any sort. Driving, there is the very good resource on the DVLA website. Used to be called At a Glance. It has this long title now, but it's very easy to find on the DVLA website. The advice from the DVLA does change little bits on a regular basis. They update it constantly. This is their rules from that guidance for supratentorial cavernous malformations. So supratentorial is everything in the upper part of the brain, as opposed to infratentorial that we'll look at in a minute, which is the back of the brain here, the cerebellum and the brainstem. The reason that there's a difference is that the infratentorial area of the brain is less prone to causing seizures, and seizures are the thing that they are most concerned about with regards to driving. And just picking a few things here, if it's an incidental finding, not treated, then there's no restriction to either group 1 or group 2, car or motorcycle, or driving a bus, lorry, a commercial license. If there is a seizure, you must not drive, and then go to the more complex seizure rules. But in general, as the very minimum amount of time that you would be off driving is 1 year, that you have to be seizure-free. But as I say, I'll not go into the seizure rules in any more detail. Another thing, if you have a craniotomy to treat the cavernous malformation, then you get 6 months where you should not be driving after that craniotomy. And that's clearly important, thinking about craniotomy as a potential treatment if driving is important for your livelihood. And that is not the same for radiosurgery. Infratentorial, as you can see, it relates to seizures, but the seizure risk, again, it relates to seizures. That seizure risk is smaller, and the difference being if you have a craniotomy for infratentorial, you may drive because there is that lower seizure risk, but if you had a seizure, those seizure risks would apply. And then, so finishing off, putting all that together, just thinking about what the psychological impact of those restrictions might be. So again, thanks to Stu for his thoughts on this, that we know with certainty that an enforced absence from school and being restricted from favoured activities leads to a reduction in quality of life assessment scores in children. And everybody has been through that experiment recently with the lovely COVID. And we've all seen what impact that has. So initially with COVID, there was a bit of a coming together, a feeling of being able to fight against this, but very quickly as time went on, and particularly I would say the evidence suggests for resource limited families that it has had and continues to have a very negative impact on well-being and particularly psychological well-being. Finding a way to stay active is so important to psychological well-being. And sorry to land this on everybody, but this statement at the end here, the biggest predictor of a child's adjustment to their long-term condition is actually their parental functioning and their parents' adjustment to that condition. I'll just very quickly finish off because I know they're of interest, and I think this is quite a nice little video of one of my patients just for a couple of minutes. This was one of the patients from a couple of years ago, had been presented to me as a possible lesion that might need a biopsy. And you can see there is this lesion right in the center here, sat in the fluid cavities, causing a blockage of those fluid cavities and a buildup of a fluid called hydrocephalus. And that did not look right, that little thing. So we, rather than just biopsying it with a needle, felt we had to have a good look at this. So this is an endoscopic view of that patient. So that's the endoscope going into the fluid cavity. This central, ooh, sorry. Oh dear. Sorry. let's try that again. Right. So this is the fluid cavity coming into the fluid cavity on the side. This is the central fluid cavity. This stuff here is the choroid plexus that makes the cerebrospinal fluid. That's made up of those tiny blood vessels that you can see. But that was the lesion there. And that, in fact, has the absolute typical appearance of a cavernous malformation. So that is what it looks like. Normally, it's surrounded by brain, but you can see this one is coming to the surface to make it look more clearer exactly what is involved. It was a little bit uncertain. This is why we're probing it here. Could this be blood vessels around an actual lump? Could this be a tumor? And these were just blood vessels rather than a cavernous malformation. But you can see the whole thing is blood vessel. It's compressible. And we'll see in a second another little bit of it pulsating away. So this was all blood vessel. You can see here that pulsating bit. And rather eerily looks like it's talking to us here as it's pulsating away. So I thought that was just an interesting view of a cavernous malformation that you don't frequently see. This young man went on to subsequently have an open operation to have this Cavenoma removed successfully. So again, showing that there are treatments that are available even in very difficult, inaccessible places. So that just runs for another minute or so. I'll just summarize what we've been through there. So in terms of the activities, there is not strong evidence that any particular activities are detrimental if you have a cavernous malformation. There are some things that would seem self-evident to probably try and avoid, but for young people and adults, having a feeling of being restricted, I think, is such a negative thing, and far better to be sensible and not feel restricted and talk what the thing that we talked about before, of taking control of this condition and taking control of your life and of doing the things that you feel are right for you and leading the normal life that you want to lead. That is just a little tube that has been put in to drain the fluid.
Thank you very much indeed, Ian. That was absolutely fantastic. And the video at the end, very interesting indeed. So there's quite a lot of questions on the chat line. So let's deal with those first. I'm going to deal with them in the order they were asked. What is a safe blood pressure rate when you have a Cavenoma, as this person would like to return to spinning classes, but too scared in case it causes a bleed?
Yeah, so again, the evidence is not particularly strong that if somebody is hypertensive, that there is more chance that their cavernous malformation is going to bleed. But along with the smoking, you know, there are some things that are just self-evident that it's something that is important to look at and treat right and appropriately and try and keep under control. So you would want to have the blood pressure controlled to within the range that whoever was looking after that was happy. And there's multiple factors that would come into that figure. There's no absolute figure for all individuals. That depends on multiple things. But you would want to see if there previously had been hypertension, that had been reversed and the levels were back to more normal levels.
Can I just ask? It was me that asked the question. I'm so sorry to interrupt you. It was me that asked the question. Sorry, I wasn't very clear in the question itself. I don't have hypertension. I don't have high blood pressure, but I know when I'm on.
The sound's gone, Maria.
Yeah, you say when you're exercising. Maria, your sound is cut off.
Cycling, if you like.
Okay, your sound
sorry.
cut off,
Sorry, somebody was calling me. So I'm so sorry about that. I do apologise. So I just thought, if there was a safe BP rate I could stick to while I'm spinning.
Yep.
That wouldn't cause me to get off either dizzy or I've caused, worst scenario, I've caused a bleed.
Yeah. So again, I think that there is no absolute figure that you can say. I think it's important to put all of it into context. So, you know, clearly it's a positive and healthy thing to be doing exercise and doing that on a regular basis. It's good for your health. It makes you feel better. Full
exactly.
Stop. And there is no evidence from that study that we saw of a large number of patients that the people that did that had a higher rate of bleeding than the ones that didn't.
Right. Good. So, thank you. Thank you so much.
That's one study, but you know, it was quite a good big study, and it would fit with what we see as well in terms of patients presenting. The vast majority have not just done really strenuous exercise, lifted 9 kilograms or given birth. They've just done nothing and it's just come on.
Right.
So my advice, that's not an impact thing. It's not a contact sport.
No, that's right.
For me, if you're not feeling unwell by doing it, then it would seem very sensible to keep doing it.
Thank you so much. Thank you.
I think the next question was probably asked before you gave an answer, but let me ask it. Would you recommend children with multiple Cavernomas avoiding trampolines and bouncy castles?
Yeah. So again, that's it is difficult because the last thing you want to do is stop a child who would love to do those activities doing them, and for that child to feel different and restricted. With all these things, it's trying to put it into context of the risk. Clearly, going on a trampoline is actually a reasonably dangerous thing, as anybody that's had children doing them will be able to attest to. And there is a risk of banging your head. Even if you do bang your head, it is by no means guaranteed that you're going to cause a hemorrhage. So it's trying to put all that risk and benefit together. Important in that is just how much the child really wants to do that. And you know, if they had a passion for a sport, for example, and then had a new diagnosis of cavernous malformation, or an adult for that matter, it's how important that sport and activity is to them, in my mind, that warrants the risk that they may be taking in undertaking that activity. If they're not really fussed or bothered and it's a higher risk thing like trampolining, then don't do it. If it's something that they really love, like rugby playing, for example, in somebody older, then you know that's for them to decide really how much do you love it.
I think Jeffrey's given a statement, so I'll just tell you, he fell from a ladder once and ended up with a subarachnoid hemorrhage. His CCN1 Cavenoma had not been diagnosed at that stage, but seemed to be no problem with calves. Did you want to ask a question, Jeffrey, or just sort of confirm really what Ian's been saying?
Basically, it was just confirming what's being said. I ended up with a subarachnoid hemorrhage. Ended up with still got them actually, 2 burr holes, and the Cavernomas didn't seem to be bothered.
No, absolutely. You know, it's absolutely, and I'm sure everybody potentially on the call that's has a cavernous malformation themselves will have banged their head at some point in their lifetime. It is by no means a predictable thing that it's going to cause a problem, and that, you know, that's a very good example, Jeffrey. Yeah.
Would you recommend a family to have an MRI if one parent has multiple Cavernoma?
So again, what I would recommend is a discussion with the team looking after you of all of those pros and cons for that individual family. It's important to look at the family in a wider context to see, could there be other relatives that possibly might have been missed with cavernous malformations that would strengthen that suggestion that this might be something that could be passed on. But coming back to that figure we talked about before, if you look at all comers with multiple cavernous malformations, Cavenomas, 75% of those will have a gene mutation, but that means 25% won't. So it's putting all of those bits of information together, and it's where you sit on that, where you want to be. Do you want to live in blissful ignorance? Do you want to take control of a situation with knowledge? Is that the kind of person you are? And there is not one that's right or wrong. It all is down to the individual and how they want to live their life.
Next, this might not be related to today's topic, prelude to that, but any advice would be much appreciated. Would you expect to experience a sharp stabbing pain roughly in the area where a Cavenoma sits? The patient is this person's 13-year-old son, and also he's grown about 10 grey hairs in that area. And any comments, Ian?
Yes, so usually, because within the brain, there are no nerve endings, there are no sensory nerve endings, you would not expect the cavernous malformation necessarily, if it is sat right within the brain, itself to be causing pain. Sometimes if it's near the surface and it irritates the lining of the brain, then that can cause a local irritation and a local pain. In terms of the hair thing, so it should not, it's probably a coincidence, but sometimes you can get sort of segmental areas of the body that get affected with various gene changes that may give you appearances like that at times, but it may well just be coincidence.
Is being upside down, for example, handstands in yoga, gymnastics, inadvisable for people with Cavenoma that have previously bled?
Yeah, so I suppose being upside down would give you a similar phenomenon to the Valsalva Maneuver, the straining kind of thing, in that it feels the venous pressure in your head goes up. That is exactly the same thing. So there isn't evidence, and it's been looked at, that has a negative impact on cavernous malformations. Gymnastics is one of those things that is supposed to be non-contact, but clearly there's a risk of falls and head injuries. And it would be a good example of, how much do you love doing the gymnastics? To what kind of level are you doing it as well? Doing it as a 4, 5, 6-year-old as opposed to a 13, 14, 15 Olympic athlete is a very different thing, and the risks are very different.
Is there any evidence people with Cavenoma shouldn't drink energy drinks, sugar-free or otherwise?
No, absolutely none whatsoever. And again, along the lines of what that would do to your physiology, whether it would in any way increase heart rate, blood pressure, or lower it, or do whatever to it, it's highly unlikely to cause any changes that would affect cavernous malformations.
What is your view on going to high altitude? For example, how high and for how long?
Yeah, so this crops up in the literature, and the cases, as we've seen from some of the things today, are there, but they're very few, and it is a theoretical thing. Again, I would sort of come back to my philosophy that how important is it to you to go to high altitude, and theoretically, the longer you were there, the bigger the risk would be, because those growth factors, there would be more drive for those growth factors the longer you were there. But to set a figure for how high and how long is impossible. It would all depend on just how much you want to do it.
Why would my child's consultant say her headaches are connected to her Cavenomas?
So the headaches, you for sure are associated with cavernous malformations, whether they are bleeding or obviously a larger bleed or not. So we know that they will have a higher chance of having headaches. Whether that is bits of oozing of blood that is causing irritation and causing that headaches, then we don't really know that. but we know there is more frequency of headaches. The other thing is that all children get headaches. If you have a cavernous malformation, it's absolutely natural that if that child with a cavernous malformation has a headache, you're going to take more notice of it than if they didn't have a cavernous malformation. So there's a little bit of observation bias in terms of the frequency of headaches, but for sure, it is seen.
I think we've maybe covered this, but would you say it's safe for a 12-year-old boy with many cavernomas to play contact rugby? We've been told previously not to. Yeah,
it's exactly that thing. And I think rugby is, again, a good example of the level of the sport. So for younger children playing it, even contact rugby, it's generally fairly low impact kind of stuff. But when they start getting a bit bigger, a bit older, then the stakes are definitely raised, and the chances of having a significant blow to the head go up. It's potentially different whether you're a front row compared to one of the backs. So there are multiple factors, and comes back to how desperate is that individual to play rugby.
Is there a possibility that the onset of tics, that is eye movements and head and hand movements, could be symptomatic of something?
So again, you're not speaking to the expert, but Grace, if she's still on, is the expert. So tics, for sure, seizures are very much an association with cavernous malformations. Tics are difficult. Clearly there is a question: could this be some form of seizure activity, or is it not? So I think very important.
Yeah, I'm still on, Ian, so I'll save you from that. You've worked incredibly. You've worked incredibly hard, and may I just say thank you so much for that really nice talk, because I've learned so much, as I always do, from joining you in these things. So tics are incredibly common, and I must say that the COVID situation has led to an explosion of tics disorder, and this has been reported at this year's BPNA, which is the British Paediatric Neurological Association. And even if it hadn't been reported, our experience of tics is that really there has been an explosion. And this is because the children obviously have become very anxious about the whole situation. And if they have a predisposition for tic disorder, then this has been exacerbated during the COVID crisis. There are several types of tic disorders, simple and complex. Cavernomas have absolutely nothing to do with the elicitation of tic disorders, but as Ian is saying, they may be difficult to differentiate from seizures. However, your clinician should be very able to differentiate one between the other by a simple video and also, a clinical discussion. So, for example, tics can be suppressed, but then the child feels an overwhelming desire to explode, and he will suddenly, or she will suddenly, have lots of tics as soon as they are liberated from stopping it. Tics are, they wax and they wane, and they are associated, so they will exacerbate with stressful circumstances, etc. The complex tics are more difficult, and they require input of child and adolescent psychiatry because they can be very difficult to manage. They are very pervasive. There's often a family history, and they may need medication. And again, liaison between the neurologist and the psychiatrist will be required as to which sort of medication is required. So I think in summary, cavernomas is not associated with tics. I've never seen them to be associated with tics. Cavernomas are associated with seizures. The two are very different clinically. And the clinician, well, his salt, would be able to help you differentiate between the two. Some of the more complex tics, like Tourette's, require the input of CAMs. I don't know whether that is enough.
Sounds very helpful to me, Grace. Thank you very much. Next question, would an MRI be sufficient for screening purposes for a child, or would genetic testing be optimal? And finishes by saying thank you very much for a very reassuring and interesting presentation.
So they are looking at slightly different things, of course. The genetic testing, whenever you do it, lifelong, will either be positive or negative. So it's not going to change during a child's lifetime, whereas the MR scan potentially would change and go from potentially nothing on the scan to something at some point in the future. So having a scan that was either very, very minimal or completely normal doesn't rule out that you actually may have the genetic change. And as we saw, there are a small proportion of people that have the genetic change that will never ever get cavernous malformations, that penetrance thing. So it's looking at different things, and it's therefore trying to decide what information you want out of those that investigation.
Someone relating to Maria's question about spin classes, and I think the same person saying had tonic-clonic seizures while cycling, otherwise exclusively complex partial seizures. Do you have any comment on that, Ian?
Yeah, again, it's this is very much Grace's area of expertise. There's no doubt that various things can precipitate a seizure, lower that seizure threshold. There are some that are very well known, like tiredness, alcohol, that kind of thing, being unwell. With these things, if you find a trigger that specifically causes a problem, then it would seem sensible to avoid that trigger.
If you want, I can pitch in a bit. I think you've said the most important things, Ian. So I remember when I was a trainee, Dr. Martland, who was my educational supervisor and is now retired, used to tell people that everyone can have a seizure if they are stressed enough. And he used to say, I mean, I don't know whether this is true or not, I'm sure it is, but I never checked it, that actually the American astronaut program actually stresses individuals until they have a seizure, such that they know what threshold that person has. So I don't know whether that's true or not. But the fact remains is that anyone can have a seizure. And what is being asked here is what are the specific stressors, and alcohol, very much so, and lack of sleep and disruption of sleep is incredibly important. And I cannot emphasize this enough. What people don't know is that when we have a child who has presented with a seizure and we do an EEG for them and that EEG is normal, the next step is a sleep deprived or a sleep EEG. And this is because we know that the interface between sleep and wake is the most vulnerable time for the brain to have a seizure. And actually, as you see that child go from awake to drowsy to sleep, you can start to see the epileptiform activity coming through. So what this means is that if a child does not have enough sleep, that interface is literally escalated. Okay, so we all know when we've been on long haul flights, we're sleepy, we're tired, we're drifting in and out of sleep in the taxi or on the coach to the transfers to the hotels. I mean, it seems like a long time ago that, but we can still remember that. And so this would be the most likely time for a child or an adult for that matter to have a seizure. Now, everyone needs to go on holidays and everyone has disrupted sleeps for parties, for celebrations, because we're bored out of our heads and watching Netflix at 3 o'clock in the morning. So, these are all very real situations. And the importance is not to deprive ourselves from the things that we enjoy, like Ian is saying, but to make sure that if we have been up till 3 o'clock in the morning watching a really nice box set on Netflix, then we give ourselves a night's 8-hour sleep afterwards and not wake ourselves up at 7 o'clock. Because we are likely to have a seizure then. So the key is if you usually have 8 hours sleep, then you should have 8 hours sleep. And if you don't, you need to be really careful. I think missing medication is a very common one. Okay. And stress, I suppose, as we discussed, is always an issue. I don't like to harp too much about stress because who doesn't have stress in their life? Okay. Even the cat gets stressed if I don't open her food immediately. So I think we have to be pragmatic here. There are things we can do and things we can't. And avoiding alcohol, avoiding missing medication, and making sure that we get the right amount of sleep are the most important factors, I think.
Thank you. Did you answer one about headaches a few minutes ago, Ian?
Yes. Yes.
Forgive me. The person said that the consultant said the headaches are not connected. So I'm not sure if that changes anything in the answer. Probably not really.
Well, it's very important to look at those headaches on an individual basis. As I said, children and everybody gets headaches, and some children get specific types of headaches, like migrainous headaches, that are completely unrelated to the cavernous malformations and need to be looked at and managed on their own. On the whole, you will see an increased reporting of headaches if you have a cavernous malformation, because of that observational bias that you're worried more when you get your headache. The brain, like I say, doesn't have sensation, but actually the blood vessels going to the brain can give pain, and that's the cause of migrainous headaches. So it's not fully understood what may or may not cause headaches, but important to look at those headaches and take them on their own merits.
If I can contribute a bit, is that okay, Ian?
Of course it is, Grace, yeah.
From the neurology point of view. So Ian exactly said the perfect thing. So let me try and expand a bit on the headaches from a neurologist point of view. So there is no doubt that if a cavernoma bleeds acutely, then we can expect some sort of headache. Would you agree, Ian?
100%, yeah.
Exactly. But most of them don't bleed acutely. Most of them are absolutely fine. And so the consultant of this patient is absolutely right, I think. The headaches are not directly related to the cavernoma. But one thing I can tell you, and this is very interesting actually, that I am the clinical lead for the complex service for NF1. And it is surprising that over the COVID lockdown, most of my NF1 patients' headaches have settled down completely. And the families report that this is because of the decreased stress that the children are experiencing from having to meet the demands of school. School work, school interaction, social communication disorders, etc. So there's no doubt that stress in itself can precipitate headaches. And I know that children with cavernomas and families with cavernomas are anxious about their children, and there is a bit of stress through that, and the stresses of the school. So whilst they aren't directly related to the cavernomas as a pathological entity, i.e. the cavernoma does not equal headache unless it bleeds, I think having cavernomas and living in a world that we live in can produce headaches. I hope that sort of answers a bit as well.
Thank you. That was absolutely brilliant morning. Thank you so very much. I mean, really beautiful slides, beautifully presented, and the questions show that people have been really interested, and we're very grateful to you. We hope we can meet you in person again sometime. To thank Grace as well for being here and for answering some questions as well. And we look forward to seeing you as well. So we've had a good part of the multidisciplinary team from Manchester Children's Hospital for the morning. And thank you very much indeed.
Can I just say in the meantime, it was so nice to see familiar faces and to see you looking all so well. It is really, really nice. And hopefully we'll see each other again in person quite soon.